A very good morning to one and all. At the outset, let me thank Dr. Meenakshi, my professor, for giving me this opportunity. This is a very relevant topic, drug-induced angle closure glaucoma. It's quite often underreported and under-recognized, so this session is to make you aware of it. Drugs can induce glaucoma by two mechanisms, open angle mechanism and angle closure mechanism. The open angle mechanism is secondary to steroid intake, and angle closure mechanism, there are two ways. One is with pupillary block and other one is without pupillary block. So eyes at risk can develop pupillary block, that is when there is a primary angle closure disease pre-existing, that eye can go into a further narrowing if pupil dilating medicines are given. So medicines which have got anticholinergics and sympathomimetic properties can produce pupil dilatation and lead to further narrowing. And some drugs like sulfa can induce angle closure without pupillary block. The mechanisms are different here. So let us move into a case of a 55-year-old lady who had no known comorbidities but presented with a sudden onset of pain and decreased vision of 4 hours duration on waking up from sleep. This patient gives a history of upper respiratory tract infection of 5 days duration and was on a cocktail of paracetamol, chlorpheniramine maleate, phenylephrine hydrochloride and caffeine. The patient had a vision of 2/60 in the right eye. The pupils were mid-dilated and fixed, and the iris cornea showed epithelial edema. The peripheral antechamber was narrow, the disc was hyperemic, and you can see spontaneous arterial pulsation. The gonioscopy showed closed angles. The left eye was otherwise unremarkable except that the peripheral AC was slightly shallow and gonioscopy showed occludable angles. The intraocular pressure was 60 in the right eye and 20 in the left eye. So diagnosis was straightforward. It is right eye acute angle closure attack or an acute PAC, and the left eye is PACS. The golden question here is, why did angle closure attack develop during sleep? Because during sleep, a parasympathetic drive is more and the pupils are smaller, so usually it doesn't develop. But this patient was on Vicodin, which is a combination of CPM and phenylephrine. CPM is an antihistaminic with anticholinergic property, and phenylephrine is a sympathomimetic. And the disease itself could have produced poor quality sleep, so parasympathetic drive would have been less. So we gave the conventional line of therapy, IV mannitol, Diamox, and topical anti-glaucoma medication, but the patient did not respond with that. The pupils continued to remain mid-dilated. So in view of high IOP and opening of arterial pulsation, and immediate therapeutic paracentesis was done. So this was successful in reducing the pressure, and pilocarpine worked and reduced the size of the pupil. And laser peripheral iridotomy was done, and subsequent visits the angle opened and gonioscopy showed open angles. So the unique points here was that the angle closure attack was precipitated in the sleep, probably because of anticholinergics and sympathomimetics in the system. So angle closure glaucoma with pupillary block develops only in predisposed eyes. An open angle, prior open angle does not develop glaucoma by dilating drops. So drug induces pupillary dilatation, and this increases the relative pupillary block by increasing the iris volume and the vectoral forces acting downwards. So medications that can induce this problem are which can stimulate the sympathetic system and inhibit parasympathetic system. There are various classes of drugs which can produce these problems. An anti-glaucoma medication, it's an irony here, the cholinergic agents can produce angle closure glaucoma. When the pupil constricts and the pilocarpine produces more rounding up of the lens because the stretch on the zonals are less, this can lead to an increase in the pupillary block. This can happen in narrow angles with zonular weakness and pseudoexfoliation. Mydriatic sympathomimetics like topical phenylephrine or topical anticholinergics or cycloplegic drugs, please be aware or please be cautious in using in primary angle closure suspects. The topical cycloplegics can significantly elevate the IOP in 2% of the normal population and 23% of primary open angle glaucoma. This is not because of angle closure mechanism. This is because the cycloplegia causes decreased pull on the trabecular mesocarp, just like opposite of how pilocarpine works. So when there is a decreased pull on the TM, there is decreased outflow and increase in the intraocular pressure. So please recheck the intraocular pressure after dilatation in advanced glaucomas. Botulinum toxin periocularly given can block the ciliary ganglion and produce pupillary dilatation. SSRIs again has got anticholinergic activity and thereby increasing the pupillary size. They can also increase the ciliary body flow and increase aqueous production. Respiratory system medicines like epinephrine has got sympathomimetic activity. The ipratropium bromide is an anticholinergic. Ipratropium bromide and thiotropium can be absorbed through the cornea and conjunctiva if the mask is not fitted while nebulizing. Salbutamol increases the production of aqueous humor. During anesthesia, there are various anticholinergics and adrenergics given during and pre-anesthesia. Atropine, scopolamine, the muscle relaxants have anticholinergic activity. The adrenergics like ephedrine and epinephrine are used. The peri-operative period also carries a risk of psychological stress and darkness-induced mydriasis. Next, coming to angle closure glaucoma without pupillary block is mainly by sulfur drugs. The mechanism here is an increased effusion in the choroid, producing an anterior rotation of the ciliary body, shallowing of the anterior chamber, both central and peripheral, lenticular swelling, and blockade of the trabecular meshes by the iris. So the typical presentation is it is bilateral, occurs after the first few doses of the drug, and the patient presents with an induced myopia and pain because of the rising pressure. The induced myopia because of the forward movement of the iris lens diaphragm. There need not be a prior occludal angle. Even an open angle patient can develop this problem. The reported drugs are topiramate, hydrochlorothiazide, acetazolamide, quinine, and tetracycline. The treatment here is to stop the causative sulfur drug. IV mannitol and cycloplegics will be helpful, but there is no role for peripheral iridotomy. This is a various list of sulfur drugs. Next, latanoprost, again to a surprise to some of us. It can be associated with non-pupillary block angle closure glaucoma. There has also been a report of ciliochoroidal effusion in Sturge-Weber syndrome with latanoprost. The latanoprost reduces the IOP by enhancing the uveous scleral outflow. So increased flow through the ciliary muscles causes swelling of the ciliary body, which pushes the iris lens diaphragm anteriorly, initiating an angle closure glaucoma. Anti-inflammatory mefenamic acid, very quite frequently given, can induce pupillary block mechanism just like in sulfa with a myopic shift. Carbagoline is an anti-Parkinson medicine, can also produce choroidal effusion and non-pupillary block angle closure glaucoma. Hematological agents can produce non-pupillary block by producing massive spontaneous choroidal hemorrhage. This is though very rare, but at-risk patients are older patients and CNVM and non-ophthalmos. So what is the take-home message? If there's a patient who has got primary angle closure disease, both PAC and PACG, we will start off with a PA. But in PACS, if you defer to do PA, then do a detailed drug history before saying, okay, you can closely observe. Drugs with anticholinergics and sympathomimetic activity may induce angle closure glaucoma in predisposed eye alone. So open angles are safe from this problem. Sulfur-induced angle closure, the mechanism is not pupillary block, so there is no role for peripheral iridotomy. Thank you.